Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. Sharda Jain, ma'am. And let me share some of the achievement of ma'am. Ma'am has done MBBS, MD from PGMER, and MANMAS FICOG, FIMSA, DHM, QM, and AHD. And she is Senior Consultant of OBGY, Department Director, Life Care Center, and Life Care IVF, Expert Ethical Committee, NMC, and Secretary General DGF, and founder and chairman North India Gynecologist Forum. And today she is going to speak on a very important topic and which is very much needed talk, that is on the topic challenges of PCOD in adolescent. So to know more about this topic, I would like to invite ma'am. Ma'am, the stage is yours. You can proceed from here.
Thank you very much, Mr. Faraz, for giving me another opportunity to be part of this. And today I'm going to talk on polycystic ovarian disease in adolescents. Very unfortunate that majority of the material which is available on the YouTube is 98% are non-doctors, non-gynecologists who give information on polycystic ovarian disease to the public. And so I think, the talks by the doctors are very much important. So let me just share my screen. Give me a minute. Uh, Present. Sir, मेरा
Ma'am, it's
present का क्यों
already
नहीं आ
shared,
पा रहा?
ma'am. Yes, ma'am. Ma'am, you can open the presentation, ma'am. It's already on the
No,
screen,
no.
ma'am. You can minimize it. Exit full screen from the right bottom, ma'am. Exit full screen.
Okay. All right.
Yes, ma'am.
Okay.
Now you open the
All
presentation from
right.
below.
So then I will start with the present.
Yeah, ma'am. No present, ma'am. Direct click
Okay.
on that presentation, ma'am. PowerPoint. Screen is already shared. After Chrome, ma'am.
अच्छा,
After
screen
Chrome,
is
there is a
already shared.
yes, ma'am. Yes, ma'am. Just click on PowerPoint
अच्छा, after
presentation and
Chrome,
make it.
bus. All
Yeah.
right. Is it here?
Yes, ma'am. Yes, ma'am. Make
Okay,
it full
that's
screen.
right.
Perfect. You can proceed.
Thank you. So today I'm going to talk on the challenges of polycystic ovarian disease in adolescent, and it will be in the form of question answer session, which is most liked by people in a public awareness program. So this is mainly a public awareness program meant for gynecologists, meant for all doctors as well as people who are suffering from polycystic ovarian disease. Uh, as you can see here, that polycystic ovarian disease of late has taken an epidemic form in adolescents in urban India. It's not a problem of the rural India. Many consensus guidelines on PCOS are there, and still there are several queries in the minds of most of us regarding the diagnosis and the practical treatment of this condition. I think today's presentation is going to sort out most of the cobwebs which are there in your mind. Now, coming to the incidence. Globally, the incidence of polycystic ovarian disease is around 15%, while in India, in urban India, it is around 35%. Uh, Polycystic ovarian disease and obesity go hand in hand. Recently, in January itself, the obesity criteria according to the BMI has changed in our country. Now it has been divided into stage 1 obesity, is where the BMI is more than 23 and above, while in stage 2B obesity, along with the BMI, which is more than 23, the waist circumference is also increased because it is the visceral fat which is the cause for causing morbidities. Now, as you can see here, that the stage 1 obesity is considered when the BMI is more than 23, while stage 2 obesity indicates that along with the BMI, if there's an increase in waist circumference or a waist to height ratio, potentially impacting the daily activities and the health of the individual. Now, as for the diagnosis is concerned, people ask what is the difference between PCOD and PCOS. They are just the same. PCOD and PCOS is a hormonal disorder causing irregular periods, acne, weight gain, and excessive hair growth. due to hormonal imbalances. How is PCOD diagnosed in adolescents? Diagnosis is based on irregular periods, clinical symptoms, and features of hyperandrogenism, that is, hirsutism, acne, very few of the blood tests, and sometimes the ultrasound. But ultrasound may not always be reliable in adolescents, so it is said that the ultrasound should be not be done in the first 8 years after the menarche. But all said and done, majority of the people when they reach the gynecologist, they already have an ultrasound in their hands. Now in 2018, the guidelines said that the menstrual cycle should be considered abnormal in adolescents if the first year post menarche any cycle is more than 90 days. It is abnormal. 1 to 3 years post menarche, if the cycle is less than 21 days or more than 45 days, it is abnormal. More than 3 year post menarche to perimenopause, if the cycle is less than 21 days, more than 35 days, or there are 8 cycles per year. And lastly, if there's a primary amenorrhea by the age 15 to 3 years post thelarchy. These are the two criteria as the primary amenorrhea is concerned. Now, question is PCOD and PCOS hereditary? Yes. Whenever there is a family history of PCOS, mother who had a PCOD, the sisters who have PCOD, there's more chances for the sibling girls also to have 2 to 4 times more incidence of PCOS. Whenever there's a family history of diabetes, hormonal imbalances, they increase the risk of PCOD. Can thin girls have PCOS? Yes. There are thin PCOS and obese PCOS, both are there. So PCOS can occur in girls of all body types, although the symptoms might differ. What tests are needed to diagnose PCOS? Blood tests like LH-FSH ratio is altered, testosterone is raised. They can be 75 gram glucose test shows glucose intolerance in a significant number of cases, and sometimes the ultrasound may be necessary. Now, screening for metabolic disorders include insulin resistance and obesity. I'm going to dilate on this. Hypertension, all women should have a blood pressure measured annually. Hyperlipidemia, all obese and overweight women should have a fasting lipid profile. Obstructive sleep apnea is one of the presentations. Emotional well-being, when people have polycystic ovarian disease and there is disfigurement of their body, it impacts on the emotional health tremendously. They are conscious about the body image issues. Eating habits are definitely not good, and the quality of life suffers in a very big way. So, to stratify the risk of developing metabolic syndrome are tabulated under essential investigations, which are listed on the left hand side. On the right hand side, it is a desirable investigation depending upon the clinician discretion. How do we document insulin resistance? Is it essential to do 75-gram OGTT test for insulin resistance? I will say it is a mandatory test. It is seen that 50 to 60% of obese polycystic ovarian disease patients and about 20% of our normal weight girls with PCOS have insulin resistance and impaired glucose tolerance test. It is desirable to do the test for insulin resistance to plan the management and counsel regarding further prognosis. Insulin resistance test commonly used is 75-gram OGTT, and here it is this particular test 2 hours report. If it is more than 140 to less than 199, it shows glucose intolerance. If it is levels are more than 200, it shows that patient has an over diabetes. Earlier, we used to do fasting glucose divided by fasting insulin, and the cutoff was less than 4.5. It is not used anymore. HOMA insulin resistance, where the fasting insulin was multiplied by the fasting glucose, it was divided by 405, and the cutoff was if it was more than 2.5 to 3.5. Again, this particular test, these lower two tests are not used anymore, except the 75 gram OGTT test is used for insulin resistance. Now, coming to the management, can PCOS be cured? Many parents ask this question. No, but it can be managed effectively with lifestyle changes and diet and exercise. So, if the parents are serious, if the girl is serious, and she adopts lifestyle changes and makes changes in her diet and exercise, then you find small amount of medications are needed, and her disease can be effectively managed. What are the treatment? What treatment? When to start? How and how long to be given? The clinical manifestation which warrant treatment are abnormal uterine bleeding, or whenever there is features of hyperandrogenism, hirsutism, which is distressing, especially in adolescent, severe persistent acne, and a temporal baldness are again cause of worry for these adolescent girls. Insulin resistance tells you about the future metabolic problems, and I just now told you the obesity is part and parcel of polycystic ovarian disease in quite a significant number of cases. 60 to 70% patients are overweight. Is weight loss important for managing PCOS? Yes. People say that even 5 to 10% weight loss can help to restore hormonal balance and improve symptoms. People like me feel that you must emphasize and counsel them at this particular time that the normalize your weight for your age. You find you will not require any treatment. It is 50% treatment. What diet helps to manage PCOS? A diet rich in fiber, lean proteins, whole grains, fruits and vegetables, and low in sugar and processed food is recommended. This processed food, white sugar, are killing. Is exercise necessary for PCOS management? Big yes. Regular physical activity and hormone balance. And this moderate exercise of 150-minute per week need to be done. Now, as for the lifestyle measures are concerned, this is advocated as initial management as an adjuvant with any other modality. So you have taken a BMI plus you have taken the weight measurements. The diet goal should be as 5 to 10% weight loss should be there. And excess weight yields significant clinical improvement. Whenever you have a loss of 10%, you find there is a significant clinical improvement. Overweight and obese advocate an energy deficit of 30%, which amounts to 500 to 750 calories per day. 1200 to 1500 calories diet per day is enough. I again remind you that energy deficit of 30% is minimum needed, which is amounts to 500 to 750 calories per day. Individualized approach for tailoring the dietary changes is important. Consider the food preferences. Avoid unduly restrictive and a nutritionally unbalanced diet. Now, reduce their carbohydrate to only 40%. We said low carb diet. They should be 40% of the total calories. People like me advocate three main meals. I'm not fond of giving three snacks. जितनी बार मुंह खोलोगे कम खोलोगे उतना ही अच्छा है. So breakfast, lunch and dinner. In between, no snacking. Avoid refined carbohydrate and sugar. These are in processed food. These are absolutely poison. White sugar is said that it can give rise to habit formation just like tobacco. Increase the fiber content in your diet by increasing the fruits and vegetables, oat, bran, barley, and advocate millets in your diet. Increase of intake of omega-3 and omega-6 fatty acids like fish, nuts, olive oil are really helpful. Tip from my side is never skip breakfast. Breakfast should be taken within 2 hours of waking up. Lunch should be 5 hours after the breakfast, and dinner should be 4 or 5 hours after the lunch. Insulin resistance and obesity. The first line of management is lifestyle modification. This includes 30 minutes of exercise every day, which is not difficult at all. With dietary restriction and interventions are advocated. Now, this lifestyle modification improves menstrual frequency, 50% start ovulating, testosterone level, as well as improves weight and insulin levels, though there is no improvement in hirsutism is seen because of the weight loss. Insulin resistance and obesity, the further it is said, the lowering the glycemic index of the diet also benefits the insulin resistance of adolescent with PCOS. You should encourage low glycemic foods. It has been seen that weight loss in obese adolescent can induce regular ovulatory cycles in at least half of the patient. Now, metformin is suggested if abnormal glucose tolerance is noted. However, lipid abnormalities of the metabolic syndrome cannot be normalized by weight loss. I will talk again on this later. Now, coming to the abnormal uterine bleeding, it can manifest as irregular, infrequent cycles or as heavy menstrual bleeding. The treatment of choice for this condition are the oral contraceptive pill, as they regularize the cycles and can improve the hyperandrogenic manifestation seen in polycystic ovarian disease as hormonal problem. Now, what are the treatment options? What medications are used for PCOS? Birth control pills, metformin, anti-androgens, and fertility medications are commonly used. Are birth control pills safe for managing PCOS in adolescents? Yes. They are commonly used to regulate periods, manage acne, as well as excessive hair growth. So, 3 point attack: periods, acne, and excessive hair growth. The choices of oral contraceptive pills, I'm making it very simple and clear. The OCP, which is available in all public hospitals, Mala D overall, they advocated for adolescents with AUB alone or associated with hypoandrogenic features like hirsutism, acne. OCP with drospirenone like Yamini and Dronis are preferred in obese girls. Remember, drospirenone is for obese girls with or without hirsutism because of the unique anti-androgenic and anti-mineralocorticoid properties of drospirenone, which minimizes weight gain and may in fact have a temporary weight losing effect. So remember drospirenone in obese girls. OCP with cyproterone acetate. Many preparations are available in Indian market like Dyne, Ginet, Crimson. Desogestrel progesterone, which is used in Novolon, are again with predominant hypoandrogenic features. Now, important tip is after few years, depending on clinical picture, the OCP can be withdrawn for few cycles to allow the recovery of suppression of pituitary gonadal function and to ascertain whether the menstrual cyclicity has been resumed. And I invariably do it after 6 months of treatment. Now, people who are short stature with open epiphysis, progestins are more suitable. Irregular and infrequent cycles without hirsutism or acne. The second possibility could be menstrual irregularities with contraindication for estrogen containing OCPs and menstrual irregularities in perimenarchal girls which have further growth potential. Which progesterone to be used? Medroxyprogesterone acetate 10 milligram. Or you can use micronized progesterone 100 to 200 milligram at bedtime can be given for 10 days each month to felicitate monthly withdrawal bleeding and to prevent endometrial hyperplasia. Now coming to hirsutism, big problem. OCPs, along with any of the following additive therapy, are advocated for a minimum period of 9 to 12 months, even longer than that. It's important to counsel the patient that the effect of COCs will not be apparent before at least 6 months of therapy. 6 महीने आप ट्रीटमेंट लोगे तब इसका असर दिखाई देगा कि हेयर ग्रोथ कम हो गई है. Now, as far as the cosmetic treatment for hirsutism are concerned, they are waxing, bleaching, shaving, using depilatory creams. They are safe options, they are cheap options, but drawback is that skin irritation and need frequently repeating the same process again and again. Eflonithin hydrochloride cream is available in Indian market. It takes about 6 to 8 weeks for the clinical effect to take place. Uh, Pretty popular with young ones who do not want to get any medical treatment done other than this. Now, as for the laser therapy is concerned, all of us you have must have heard about it. That is, it removes the hair permanently by thermal destruction of the dermal papilla, and the high cost and the repeated session is its biggest drawback and limitation. Electrolysis was used earlier than the laser came. This again removes the hair permanently. Here, the learning curve is little more. It destroys the dermal papilla, and it is slow, expensive, and you require expert to do the job. Anti-androgens can be started if derma interventions do not bring the desired results in 12 months' time. They should always be prescribed with OCP because they may cause menstrual irregularity and because of their potential teratogenic effect. There is no clear cut guidelines what should be the duration of treatment with anti-androgens. But these girls must be counseled that whenever you're taking these drugs, they can have a potential teratogenic effect. So you should always and always take it along with OCP so there is no pregnancy. The anti-androgens drugs available are spironolactone. This is given in the dose of 100 milligram twice a day for 9 to 12 months, followed by maintenance dose of 50 milligram twice a day. Flutide in dose of 250 milligram BD or subsequently OD can be given. People like me do not have an experience. I like spironolactone, that is aldactone. Cyproterone acetate is a progestin which is combined in low dose of 2 milligram with estradiol in some formulations which are available in Indian market. It can also be given in higher doses with any form of estrogens. The limiting factor for this is hepatotoxicity. So you have to get this particular investigation, liver function test done before the start and subsequently on a follow-up. The role of insulin sensitizer, that is metformin. A minimum of 6 months treatment is required to improve the menstrual cyclicity and metabolic parameters, which may be extended over longer period if required. The baseline metabolic panel should always be done before starting metformin because it has serious side effects of lactic acidosis. Metformin is contraindicated in cases of hepatic diseases, renal diseases, patients with cardiac insufficiency, and people who are chronic alcoholism, as it can cause lactic acidosis in these conditions. So, this particular point must be remembered as far the metformin is concerned. Now, this particular slide summarizes everything. We have a classic hypoandrogenic oligoanovulatory and polycystic ovaries. All features are there. They can have a normal BMI. These patients require only low dose OCPs with CPA or desogestrel. People who are obese require diet and exercise modification, and they have to include diet energy curtailment and exercise 30 minutes per day. These people should be given low dose OCP pill with drospirenone. I told you all obese patients should be given drospirenone OCPs. Add metformin if impaired glucose tolerance test is found or type 2 diabetes is noted. If there's no relief of hypoandrogenic symptoms in 6 to 9 months, add anti-androgens, that is spironolactone along with OCP. Patients who are obese, who have a BMI of more than 30, You can try modern drugs also. But these two alternatives which have been given here, they're almost withdrawn. Now, coming to the second category, hypoandrogenic features and oligoanovulation. Same treatment. First line treatment, first line pharmacological management, and the second line treatment. Ovulatory cycles with hypoandrogenous features and polycystic ovarians, again, the treatment is the same. Coming to the last variety, phenotype of the polycystic ovarian disease, who are non hypoandrogenic, there is oligoanovulation and there are polycystic ovaries are there on ultrasound. Again, the first line treatment is the same depending upon what is your weight like. You can also give these patients progestogen for 10 days every 4 to 6 weeks, or you can give them a low dose OCP if the contraception is also desired, at metformin if there is an impaired glucose tolerance test or diabetes mellitus. Second line treatment is low dose COC if cycle control not satisfactory with progestogens, then you can use OCPs. Now, question is asked by the parents: is surgery required for these polycystic ovarian disease? Because there is a in polycystic, so they feel that probably the surgery will be required. You have to say rarely it is required. Ovarian drilling is an option for severe infertility, but is seldom needed. Bariatric surgery, WHO says that if the adolescents are that obese that they require a bariatric surgery, the parents should not hesitate. Now, as for the infertility concerns are concerned, again, this is a big question by the parents. Does PCOS always cause infertility? Big no. Many women with PCOS conceive naturally if they normalize their weight or with mild medical assistance. When should I worry about fertility if I have PCOS? The fertility concerns are addressed when you plan to conceive, not during the adolescence, so do not worry about it. Can PCOS be treated to improve fertility? Yes. Normalize your weight. Medications like ovulation inducers and lifestyle changes will help. Big way. Is IVF the only option for PCOS related infertility? No. Most women conceive with simpler treatment. IVF is used only in complex cases, classical PCOD cases. Mental health and emotional well being is very, very important, and all clinicians should not forget this. Why do girls with PCOS feel stressed and anxious? Hormonal imbalances and physical symptoms impact the self esteem and mental health in a big way. Can PCOS cause depression? Yes. Hormonal changes and body image issues can contribute to depression in 15% and anxiety in good 50% of cases. We will take some time a presentation on the psychological aspect of PCOD, how it has to be handled. How can a mental health be managed with PCOS? It requires counseling sessions, support groups, and the stress relief practices like yoga can help. When it is severe, you require psychiatrist consultation as well. Long-term health risks. Does PCOS increase diabetes risk? Big yes. PCOS is linked to insulin resistance and thus at a higher risk of type 2 diabetes. Another question is asked: can the PCOS cause heart problem? Yes. It increases the risk of high cholesterol, high blood pressure, and heart disease. I've seen girls, not adolescent, 23, another was 24, massively obese, more than 100 kg weight, coming with MI and dying within 24 hours in Max Super Specialty Hospital, Saket. Is PCOS linked to cancer? Irregular heavy periods can slightly increase the risk of endometrial cancer if it remains untreated. And that is why all these cases or cases of heavy periods need to be treated. Does PCOS affect menopause? PCOS can delay menopause, but can worsen symptoms like weight gain later in individual's life. Lifestyle and myths. The question is often asked, is PCOS caused by eating junk food? No. But unhealthy diets can worsen symptoms in genetically and harmonically predisposed individuals. The people who are genetically predisposed, people who have an abnormal hormonal profile, these patients, if they eat food from outside, junk food, it is going to definitely aggravate the problems. Can home remedies cure PCOS? YouTube is full of this. No home remedies can cure PCOS. But natural methods like diet and exercise can improve symptoms. Normalizing weight is 50% treatment of polycystic ovarian disease. Another question sometimes asked, is PCOS contagious? No, it is not contagious. Can PCOS go away after marriage or pregnancy? No. The PCOS is a lifelong condition, but symptoms may improve with age or hormonal changes. And once you realize that if I normalize my weight, my symptoms will disappear. Now, as for the follow up is concerned of these adolescent girls, how often should I see my doctor for PCOS? Every 3 to 6 months. Doctors will help monitor your symptoms and the treatment effectiveness. Do I need regular blood test? Yes. Periodic tests of CBC, ruling out diabetes from time to time, serum creatinine for kidney function tests, SGOT, SGPT for liver function tests. Your lipid profile also needed. And if you find that your symptoms of hyperandrogenism are not subsiding, you probably need to have a testosterone level also done. Is ultrasound needed every time? No. It is only needed if there are changes in the symptoms of fertility planning. Now, this is Ludwig scale for alopecia. It has got three categories. Type 1 is minimum thinning with hair density that is normal or only slightly reduced. Type 2 is mild thinning, and there is a noticeable reduction in hair density. And type 3, there's a significant thinning with a moderate to severe reduction in hair density. And this is, I think, all gynecologists must be familiar with this Ferryman Galway score. And once they start using in their day-to-day practice, they can definitely score without losing much time. So this presentation of mine, based on frequently asked questions, can serve as a foundation for training modules to empower gynecologists in India with culturally relevant evidence-based knowledge to manage PCOS effectively and answer all PCOS highly charged patients and their parents. Thank you very much. I will stop presenting. Done. Sir Sarfaz, if there are questions, we will take.
Thank you so much, ma'am, for taking out your valuable time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice also. Like the knowledge you have shared will be very much helpful to all the audience also. Like, ma'am, we can see we have received some questions from the participants. With all your permission, shall we take these
Please,
questions?
please,
The
please,
first
please.
question I can see from Dr. Subramaniam, he is asking like how do insulin resistance and hypogonadism present differently in adolescent PCOD?
Uh, there are two forms of PCOS. One is obese, which is very common, but there are thin PCOS patients can also have insulin resistance. It is seen that the people who are thin, insulin resistance is seen in 20% of patients. People who are obese, it is seen in good 60% of cases. And the simple test is done, which is 75-gram glucose load is given, and you take a sample 2 hours later. If it is between 140 to 199, it is glucose intolerance, which can be managed very easily with metformin. And if it is more than 200, it classifies that particular person having a diabetes. So this is what is required. As far as other hormonal tests are required, LHFS situation we used to get it done earlier, but we are not getting it done now. The only test which we get it done is a total testosterone things, along with the baseline CBC, liver function test, kidney function test, that is serum creatinine, and a lipid profile. We get it done.
Thank you so much,
Yes, sir.
ma'am, for sharing your expertise on this question, ma'am. I hope that Dr. Subramaniam has received his question, ma'am. Ma'am, from we have one more question from Dr. Vipa Upadhyay. Like, she's asking, is there any foolproof treatment plan for PCOD for a successful pregnancy? Kindly advanced treatment of obese PCOD patient, ma'am. Two questions she has asked together.
See, all patients, it is the topic which is outside the adolescent period. But yes, when this adolescent girl becomes a young woman and she wants to have a child, one thing is right in the adolescent period, there should be counseling should be done, that you have to curtail your diet by almost 30 to 40%. And you have to, this 1200 to 1500 diet is good enough. You have to counsel her what she has to take. It has to be high fiber, low carb, high protein diet these people have to take. And 50% of their food should be fruits and vegetables. So I think, diet has to be emphasized, exercise need to be emphasized. And once they have normalized their weight, they'll be ovulating regularly. Majority start ovulating themselves. The people who do not ovulate, if you give them ovulation induction, they respond very readily. So the 50% of the treatment is normalizing your weight, doing exercise and lifestyle things. No food from outside. And you can find 80% of patients of polycystic ovarian disease readily conceive. I will say readily conceive. There are four phenotypes. The first phenotype is a classical type. These patients are really obese. They have periods coming 6 months, 1 year में आते हैं. They have a hyperandrogenic features. These are the patients who have not been able to decrease their weight. These people land up in problems of IVF. Otherwise, rest 80% polycystic ovarian disease, if managed by the good gynecologist, will able to conceive.
Thank you so much, ma'am, once again for answering this question, ma'am. I hope that Dr. Vibha has received his answer. Ma'am, one of the very important question I can see from Dr. Umesh, and he is asking, like, ma'am, how to deal with the patient. Like, once we give the medicine of patient of PCOD, but after taking some time, once they feel that there is a relief in the PCOD, they stop taking medicine and reoccurrent happens. How to deal this kind of patient, ma'am, like to make them understand.
See, there are three components of the treatment. One is lifestyle, normalizing weight, exercise. ये तो करनी करनी है. एक बार वेट नॉर्मल हो गया तो आपको कोई ओसीपी की, कोई भी किसी चीज की जरूरत नहीं पड़ेगी. बट वंस आपने ये कंट्रोल खो दिया, आपका वेट वापस पहुंचने लग गया, आपने एक्सरसाइज भी बंद कर दी, तो फिर आपको वही से दोबारा यू कम बैक टू द सेम पॉइंट. And you have to again do the lifestyle, you have to reduce your weight, and you have to follow a lifestyle changes. So एक मैसेज आपने जरूर लेके जाना है. 50% ऑफ द ट्रीटमेंट ऑफ पॉलिसिस्टिक ओवेरियन डिजीज इज नॉर्मलाइज योर वेट. जो आपकी एज में वेट होना चाहिए उसको आप कर लोगे तो आपको डॉक्टरों के चक्कर ही नहीं लगाने पड़ेंगे. People who
Uh,
understand this particular thing, who have normalized their weight, they never have any problem in conceiving. They conceive
yes,
readily
ma'am.
and deliver just like a normal people. Yes,
Yes,
sir.
ma'am. Thank you so much, ma'am, for sharing again some insightful support to this question, ma'am. I hope that Umesh has received his answer. Another question, ma'am, I can see from Dr. Sangeeta, and she's asking, like, at what stage should clinician start investigating irregular menstrual cycles for possible PCODs?
See, I gave you one slide. In 2018, things became very, very clear Then anytime you find, the cycle is going more than 90 days, anytime you find that the cycle number is less than 8 per year, or anytime you find, after first year, that the cycle is less than 21 days or more than 45 days, these are the patients who probably have polycystic ovarian disease as well, and these are the patients should be managed accordingly. And if there is a need you feel, you can to have an ultrasound, you can definitely have an ultrasound also done. Yes.
Thank you so much, ma'am, for answering this question. I hope that the clear doubt of the Dr. Sangeeta has been cleared by you. As I can see, there is no more questions. I hope we have done justice to this topic. And when couple of feedback, one from Dr. Prerna, well explained and amazing presentation,
Thank
and
you
one
so
more
much.
feedback from Dr. Chanchalani, and she has written, "Thanks, ma'am. It's an honor to listen to you."
Thank you very much.
And yes, ma'am. Like I hope that you have
Thank
made
you.
this webinar a wonderful and very practical to all the audience, ma'am. So, like
The
there is
only
no
thing
more
I
question.
want, sincere wish is that whenever you have a problem of polycystic ovarian disease, or you are the parent of the child who has a polycystic ovarian disease, please read articles of doctors and doctors only. Don't read
Yes, ma'am.
articles of non-medical. Please.
Correct, ma'am. Like we are living in a time period, ma'am, where the like social media influencers are leading, and they're misguiding and giving their own like own tips and own type of team to deal with that things. I hope that it will be very much
Well,
helpful,
I
like
think this
expert.
this platform like yours should encourage more and more doctors. That they should take sessions which require a lot of public awareness, lot of public
Correct, ma'am.
awareness.
Totally
So
correct, ma'am.
I
It's
think this particular platform, especially led by Dr. K. Agarwal, had been very popular. He was very fond of public awareness, which is really needed.
yes, ma'am. Ma'am, thank you so much, ma'am. Like he has gone, but like his message was that the show must go on. It means like
Go on.
doctors like you only promoting the awareness among the society, ma'am. I hope that one day the health awareness will be available door to door, urban to rural areas too, ma'am. With your efforts, ma'am. It's a great honor to have you,
Thank
ma'am.
you very
Thank you.
much. Thank you very much. Thank you very much.
Take care, ma'am. We would like to see you in future also with different topic. Till then, take care of
Yes, yes,
yourself.
yes. Thank you. Thank you
Bye,
very
ma'am.
much.
Thank you.
Thank you.